good evening, everyone, and a very warm welcome to today's special session, Beyond Tremors, Rethinking Parkinson's Care and Innovation, brought to you by Voice of Healthcare. On the occasion of World Parkinson's Day, we have come together to raise awareness, deepen understanding, and most importantly, reimagine how Parkinson's care is delivered in India and globally. As we know that Parkinson's disease is often associated with tremors, but as we all know, it goes far beyond that. It is a progressive neurological condition that impacts movement, cognition, mental health, and overall quality of life. In India alone, over 5.8 lakh individuals are living with Parkinson's, making it a significant and growing public health concern. Despite the advancements in treatment, challenges around early diagnosis, access to care, long term management, and caregiver support continue to persist. And what we aim through this discussion is to explore that how we can strengthen the early detection pathways, accelerate adoption of advanced therapies, build multidisciplinary and scalable care models, and to foster stronger collaboration between clinicians, industries, and policymakers. And to begin with, we have an esteemed panel of experts with us today who will bring deep clinical, rehabilitation, and caregiving perspective to this conversation. Let me take a moment to introduce our distinguished panelists for the discussion. Starting with Professor Dr. Paresh K. Doshi, Director of Neurosurgery and Stereotactic Functional Neurosurgical Program at Jaslok Hospital, Mumbai, and a globally recognized leader in neuromodulation and restorative neuroscience. Welcome to our show, sir. Thank you so much for joining. Dr. Charulata Sankhla, Consultant Neurophysician at PD Hinduja Hospital, Mumbai, and Vice President of the Parkinson's Disease and Movement Disorder Society, with extensive expertise in movement disorders. Welcome to our show, ma'am, and thank you so much for joining.
Thank you.
Thank you, ma'am. Dr. Tarun Lala, Zonal Head in Physiotherapy and Neuro Rehabilitation at Max Healthcare, who brings a critical perspective on rehabilitation and functional recovery in Parkinson's care. Thank you so much for joining, sir.
Thank you.
Thank you so much. Dr. Manpreet Kahlon, Chief of Customer Relationship at Amoha Elder Care, who will share valuable insights from the caregiver and patient supports ecosystem. Thank you so much, Dr. Manpreet, for joining. Thank you so much, ma'am. Once again, I would like to extend and welcome you all, welcome all our speakers and audience joining us live. To begin our discussion, starting with understanding Parkinson's landscape and where do we stand today. So, Dr. Charulata, I would like to start from you and would like to understand that what are the most common early signs of Parkinson's that are still being missed or, misdiagnosed in India?
So the Parkinson's cardinal signs are the tremors, which are not present in all the patients. They have stiffness in the muscles and they have difficulty in walking, difficulty in turning, difficulty in doing fine movements. Now, when the patient develops the tremors, then definitely the patient seeks the medical advice. But there are many Parkinson's patients who do not have tremors, and these are the patients who don't tend to come to the neurologist very often. They are the Parkinson's patients who do not have prominent tremor or who do not have the tremor at all. They present with stiffness in the muscles and difficulty in walking. So these are the patients that are often missed and come late.
Thank you so much, ma'am. Thank you for that explanation. And I think that is something which we look forward to, as we know that how these signs and symptoms are missed or misdiagnosed, where we want to educate our audience to, to focus on or not to delay in the screening part. Moving ahead, I would like to ask my question to Dr. Paresh. So, as we discussed about the early signs, Now, at what stage do patients typically reach to you for surgical intervention? And does this reflect delayed diagnosis or referral gaps?
Yeah, so difficult to tell only for tremors. Usually, as Charu mentioned, it initially starts with tremor, but as the disease progresses, I would say 7 out of 10 patients can be controlled very well medically. I would say approximately 20% or 25% of the patients' tremors are difficult to control with available conventional medical treatment, and they may want to seek medical help. And these are very small group of patients. But as the disease progresses, the patient do seek help and surgical treatment for various other reasons or other problems related to Parkinson disease. Let us presume that the patient who is having tremor, dominant Parkinson disease, and having significant amount of tremor is seeking medical help. Then the surgical treatment for the tremor can be offered. And what surgical treatment we can discuss later. But usually, in my own experience and expertise, I feel that most of the time the tremor should be well controlled with proper medical treatment.
Thank you, sir. Thank you for that answer. As yes, we are going to discuss about the surgical intervention later, but how you explain that yes, we can control the tremors with medication. So, moving ahead to Dr. Tarun. So, when we talk about rehabilitation, so how early are rehabilitation intervention introduced in Parkinson's care, and what impact does delayed initiation have on patient outcomes when you deal with all these cases and patients on daily basis?
Yeah, thank you for the question. First of all, I would like to thank you for having me here with the esteemed panelist, renowned neurosurgeon Dr. Joshi, and our other co-panelists. Thank you for that. And let me get back to the question that you have asked. I think now the paradigm shift is massive. So when you talk about delayed rehab versus early neuroprotection, so that is the keyword, early neuroprotection. That's what we are looking at. So, now if I go back 10, 15 years, 20 years back, I used to get patients who would have motor, disabilities like, gait issues, swallowing issues, walking issues, all those posture issues. But now things are changing. Now, I think what we are doing is more of, at the time of diagnosis only, we are starting with the rehab, so that really helps in terms of, protecting your neural system, delaying your symptoms. And like you said, the second half of your question was, if a patient comes to me with the delayed symptoms and patient already is in that phase where he has difficulty in walking, difficulty in eating, and then at that time it becomes very difficult as a rehab specialist to treat those patients. Not that we don't have enough treatment, yes, but then it's a whole lot of effort in terms of patient, in terms of the family burden, right? And of course the cost and everything gets multiplied in the 2 and 3 times more than what you would have achieved if a patient would come to you at the time of diagnosis. But now, yes, things are changing and we are getting patients as early as possible, at the even if they are not getting into that area where there's no movement disorders, I would say, in terms of mobility issues. We are getting them quite early, so it becomes very easy for us to deal with such patients.
Thank you so much, and I think this is a positive impact that we have seen that now how patients are
Sir
turning
is
early
saying
to the.
something. I think Dr. Joshi wants to say something.
Yes, sir.
Yeah, I absolutely agree with Tarun. Tarun, you are very much correct that early intervention, especially for Parkinson disease in rehab and taking care of themselves, will go a long way. We
Right.
conducted a study on dance plus meditation or music plus meditation in a double-blind randomized controlled trial 3 years back at Jaslok Hospital. It has been published in literature, and we could show that a properly organized dance therapy plus meditation or music therapy plus meditation was able to slow down the progress of Parkinson's disease by 4 points of UPDRS in a short
Wow.
span of months, in a span
That's
of
amazing.
months. So
That's
this
amazing.
is a very important point, and I think if Parkinson's patients are listening to this, they should take it seriously. this is another form of treatment.
Absolutely.
Thank you so much, sir, for highlighting that, and thank you so much to Dr. Tarun also that how things are turning positively. That people are turning to doctors at early, and before it's too late, or it becomes difficult to control the signs and symptoms. Now focusing our perspective to the caregiver. So now my question is to Dr. Manjeet. Ma'am, from a caregiver's perspective, what do you see are the biggest challenges faced immediately after diagnosis?
So, Kiran, the first feeling that a caregiver usually is either the spouse or the kid. So, generally, the first feeling that they have is a feeling of denial. The moment the diagnosis happens, it's a denial which comes in first, and then anxiety sets in, and then they are more worried about progression of the disease rather than managing the immediate symptoms. So another thing I feel in Parkinson's is because there are so many doctors visits, so many follow-ups, just to catch up with those kind of things, I think more becomes a logistical issue, and also they are more worried about that rather than the disease itself. As doctors rightly said that there are a lot of other treatments which can be done at a very early stage, but a lot of caregivers neglect this just because of their own anxiety, just because of their own expenditure which is going up because of the disease, and also long term that they're thinking about that as the disease progresses, it's going to be even more difficult for us. It's going to be heavy on our pocket. It's going to be more of a logistical issue for us to have those follow-ups. And also in Parkinson's, I'm sure doctors can mention that later, that timely medication is very, very important. So a lot of them have to maneuver their whole daily routines according to the medication to be given exactly on time. So these are the certain things that the caregivers are initially very upset about or very anxious about. Slowly, steadily, they do get adapted to the whole situation, but then the disease also, the condition also progresses accordingly. So it becomes even more difficult for them.
I agree, ma'am, that how things starts with the denial, and then it turns out that they have to accept the reality and react accordingly as things or the disease will progress, and they have to be more vigilant with the patient. So thank you for highlighting on that aspect. Moving ahead with our second topic of discussion, which focuses on the innovation and treatment, that what is changing in Parkinson's care. Starting with Dr. Charulata, ma'am, we spoke about the early diagnosis, screening, signs and symptoms, rehabilitation, and the caregiver's perspective. Now, when we talk about the advancements, how do you see that the advancements in pharmacological therapies and precision medicine are changing the way Parkinson's is managed today?
Definitely, there has been significant advances in the patients with Parkinson's disease treatment. As correctly pointed out by both Dr. Doshi and our colleagues, that the physiotherapy is an essential part, and initially it was not really highlighted by the neurophysicians, as well as the patients also did not realize the importance of physiotherapy. As far as medicines are concerned, we few years ago, like almost 20 to 30 years ago, most of the Parkinson's medications were not available in India. So now we have all the medications which are available overseas, all over the world, are now very easily available in India. We also have the newer modalities of treatment like rotigotine patch, apomorphine injections, and now we are waiting for the launch of the levodopa injections in India by the pharma company. So it's not that we are not keeping up the pace with the rest of the world. We are now keeping up with the rest of the world as far as the treatment of the Parkinson's disease is concerned. The treatment is very individualized. If you see a young patient with Parkinson's disease, you are going to think of different modalities of treatment. We are going to approach him surgically a little bit earlier than the older patients. Whereas the old retired people who are over 70 or over 80 years of age, the approach to those particular patients would be different. We are also now increasingly realizing that the Parkinson's disease is not just one disease, but it's a syndrome where there are a lot of etiologies, that means the causative agents that are responsible. One of them is the genetics, so there's a lot of advanced that has occurred in the genetics of Parkinson's disease and the understanding of different types of genetic forms of the Parkinson's disease. So we are definitely making progress. We are now looking at the drugs to stop the progression of the Parkinson's disease. We haven't been really successful in that, but yes, there are many trials that are going on to stop the progression of the Parkinson's disease.
Thank you so much for highlighting on that part, ma'am. And then we are sure that these trials, these advancements will come out very soon and will help the Parkinson's patients and the families out there, and most importantly, the doctors. Whenever the new treatment options, something like comes up, it really helps doctors to treat. Ma'am, you were saying something? Okay. Moving ahead with the next question to Dr. Paresh. So we spoke about the medicine and the precision medicine, that how we have any solution that can manage the Parkinson today. Now talking about the deep brain stimulation. So how has this evolved over the years, and what new innovation are improving the patient outcomes when you deal with them?
In last 10 years, we have seen almost a tremendous amount of progress in the technological advancement of deep brain stimulation. Along with that, a lot of new knowledge about the application of deep brain stimulation has come, and it is not possible for me to summarize all of them in this even 1 hour, but let me put it 3 or 4 important aspects which I think are important and game changer. One is most advanced pacemakers, which gives us the flexibility of fine-tuning the stimulation to nth level. We have millions and millions of combination. Now you would intuitively question me that if there are millions and millions of combination, how do we get that right? To put that right, various technological advancements have occurred in view of availability of various platforms which can guide us to how and where to stimulate. Second advancement has occurred in the imaging. Today we are having much more detailed availability of imaging technology and facility and expertise to imagine the subthalamic nucleus, which is the main target for Parkinson's disease, more accurately, and that has given the confidence to majority of neurosurgeons to perform asleep DBS. They are talking about targeting the patient subthalamic nucleus under general anesthesia. Whether I agree to that or not is a second question of debate. Again, that doesn't need attention here, because that's a very technically challenging discussion. So, but yes, there is a possibility of putting a patient to asleep, which is one of the anxiety with the patient to undergo surgery under awake condition. So technological advancing in imaging, technological advancing in deep brain stimulation pacemaker, technological advancement in the type of electrodes that we get. Initially, we used to stimulate with 4 contact point. For last several years, almost 8 to 10 years, we have been using 8 contact points electrode with directional current, and we soon will be using 16 contact point electrodes. This gives us the ability to target simultaneous various areas of the brain. And if you have to ask me to put it in a single line as to all these technical advances and many that I have not discussed, I would say deep brain stimulation has moved from an empirical treatment option to a personalized, specialized therapy, which is individualized based on each and every person's disease profile, need, social profile, and what his expectations are there out of surgery.
Thank you, sir. Thank you so much for explaining us in this simply yet a very difficult and a technical aspect to understand. But we really value this, how this has reached to our audience, and how it is helping and change and evolving over the time, that it has now become the more personalized for the patient's need and their disease specific. So I think this is a very positive turn which Parkinson's treatment has taken. Now, moving to my next question, Dr. Tarun. So, we talk about the deep brain stimulation, which is one of the treatment options we have. Talking about the rehabilitation, what role do structured rehabilitation program digital tools like wearables or remote monitoring play in improving the mobility and independence of a patient?
Yeah, thank you for the question. I think it's a very valid, and with today's time, I think everything is moving to assistive technology, and a lot of therapy is moving from hospital to home, right? So I think it's very challenging, but at times I think very interesting, and also benefiting to the patient. Right now, they're like the other colleague of mine said, it's very difficult for patients to travel such a long distances to a hospital to get a simple consult from a doctor. Now imagine going to a two-tier or three-tier cities where you find a good neurologist, and I would say a motor disorder neurologist or movement disorder neurologist. To find a good movement disorder neurologist, you have to travel 100-150 kilometers, and you can imagine the condition of the patient and the family to do a revisit to that doctor. So I think this virtual consults from the doctors and therapists have changed quite a bit. So coming to the virtual consult, I would talk about more of virtual reality programs that we are running now. So these are sensor-based therapies which can be monitored. Right, if I'm sitting here at Max Hospital, I can monitor my 10 patients who are in exteriors in India, maybe in Bihar, UP, and interiors of the city. So I can actually monitor them sitting here. And there are a lot of platforms and apps available now which we give to those patients, and in a real time we can get a feedback from that patient. For example, there are a lot of sensors now which are coming in the shoes. You have those wearable sensors in the shoes, and you have those wearable belts which you are giving to the patient, and these sensors are actually giving you a real-time feedback if there's any deviation while walking. So for example, an ex-patient, I've given a program that you have to do exercise therapy for at least 150 minutes in a week. So that means at least if you take 5 days in a week, so you have to do intensive rehab for 30 minutes. So he can do a self therapy. Of course, we have to teach the caregiver or an attendant. At times therapy has to be under supervision. But then what happens, once the therapist or the patient is doing these exercises, the sensors are actually giving us the feedback. Was there any deviation from a normal walking? So when I say cadence is the speed of walking, the way of walking, the pattern, the gait pattern. Gait is a technical word which means the way you're walking. So that sensor is actually giving me a feedback. How many times was there a deviation in walking for that patient, or for that matter, how many times the posture was stooping if we are giving those sensor belts to those patients. And then we can review that data, and it is giving me an objective analysis. And then what happens, I again connect with those patients virtually. They don't have to visit me every time. I can connect to them virtually and explain the attendance. Like it's like you must have heard about doing a halter. So what does a halter do? It gives you a complete image and complete readings about your cardiac health, your breathing pattern, and everything. Same way, these sensors are actually giving you real-time feedback, and then you can slowly tweak according to you. You can redo the program. You can tell the attendants, this is the area I feel it is not safe. Patient is at a high risk of fall, because fall prevention, I think, is prime most for the Parkinson's or patients who have any sort of tremors. They have maximum falls, and the latest studies have shown most of the falls happen in the washroom, in the bathrooms. And many a time they actually land up breaking their large bones, long bones. They would land up having those hip fractures. So imagine if you could prevent all those things just by those virtual consults and sensors, how healthy and how easy it will be for the patient and for the caregivers. So I think that's how the technology is evolving, and there are a lot of studies which are showing that these wearable sensors have really changed the life of the person.
I would fully agree, sir, that how the technology has helped us move and evolve and take a better care for our patient in terms of while as we are discussing about the Parkinson disease. So yes, and I remember a discussion with one of the MDs of a hospital that he said in the next coming 50 years, the healthcare will be remote and more personalized. I think we are on a path of more
Yes, and
personalized
also it will be moving from hospital to home. That
home.
transition is
Correct.
coming now. So a lot of things are actually you can actually do at home. So it actually saving a lot of money to the patient. So that same amount, that same money can be utilized in other things.
Other things, and that's how the healthcare becomes more accessible. I believe so.
Accessible, yes.
Yeah. Thank you so much, sir, for stressing on those aspects and enlightening us and our audience about the more remote monitoring and the variables and how technology has helped us move ahead. Moving to my next question, Dr. Manpreet. Ma'am, we just spoke about, Dr. Tarun just spoke about the, remote monitoring and variables and how technologies has helped. My question is on the same line, that how technology and support system better empowers caregivers in managing lower term Parkinson's care.
Absolutely. So technology and support systems definitely reduce the stress that the caregiver is going through. As Dr. Tarun rightly mentioned, that there are so many things available, even from technological aspects, so many sensors available, so many wearable devices available wherein fall can be prevented or fall can be alerted, and where a gait can be detected if it was right or how it was. And earlier, as people, as the doctors used to ask, okay, you let us know what is the sleep pattern, how much did the patient sleep, how many hours did he sleep, what was the movement, did he move, did he not. Now with these AI tools, a caregiver stresses much lesser because the whole AI tool itself takes in the data from the patient and they relay back to the doctor. And so that the treatment can continue according to whatever the symptoms or whatever the things have improved or deteriorated in a patient. And also a lot of other AI tools, as Dr. Tarun has also mentioned, a lot of other AI tools are also there, which will continue helping the caregiver also. In fact, a very common one these days is the smart pill dispenser, which gives alerts, which gives timely alerts to the caregiver. Okay, this is the time for the medication. So again, because it's anyway stressful for a caregiver who's looking after a Parkinson's patient, it becomes much easier for him also to have a routine and continue with his daily chores rather than just doing one job of caregiving, because caregiving itself is a very, very emotionally draining process. So for some time initially, because Parkinson's is a condition which goes in a very slow way. Progression is relatively slow. So initially, caregiver is usually a family member. Then only they get somebody from outside who's to look after the patient when they are unable to manage the many symptoms, or maybe when the elder cannot get up at all, or when the tremors are extremely high, where they cannot eat on their own, they require help with each and every chore. That is when they get some external help, and external helps also under the monitoring of some family member. External caregivers, when you get somebody from outside, the kind of emotional bond or the kind of feelings that you have for your own family member, it's very hard for anybody else to empathize in the same way. So it's always hard for a family member to see, even if you hand over the person to the caretaker or the carer who is looking after. So these AI tools definitely help, and there are so many sensors available which can be put in the room itself, and you will come to know when did the elder get up, when did the elder lie down, and as I mentioned about the sleep pattern, about the gait, etc., can be directly relayed to the doctor. So these are the advances, I think, which have actually happened. And the support groups, I feel support groups need to have a little more kickstart or a little more progression in India. It is not happening the way it should. So support groups, they give a lot of emotional support, especially to the caregivers, because such kind of conditions like Parkinson's, like dementia, most of the carers do not know what progression is going to be. They have just heard from people saying, okay, this is the first stage, this is the second stage, this is the third stage. But when you talk to the same situation that the other person is going through, there are a lot of small little advices which can actually help to relieve your emotional stress that you're going through. So this is all I have to say about technology. And
very rightly pointed out, ma'am, that how as along with the disease or along with the patient, we also have to give support to our caregivers also, because it definitely becomes a full-time task for them to take care of a family member who's going through this, and emotionally draining and stressful also. as you know, it is very difficult to see their family members in such condition. And if technology like this and groups like that can support the caregivers in all the aspect, I think that will be a more support system and a helpful way out to make this a little bit easier.
Absolutely.
Thank you for stressing on that, ma'am. As we are talking about the Parkinson disease and the treatment and innovation, now looking forward to the building a future-ready Parkinson's care ecosystem, I would like to ask Dr. Charulata, ma'am, what systematic changes are needed to ensure that the early diagnosis and standardized Parkinson care is there across India, as we spoke about what is there, what can go wrong, what can go right. Now to prevent it, how we can build up such ecosystem for early diagnosis.
Taking it from the earlier speaker, I just want to make a comment on the support groups.
Yes, ma'am.
So I am a part of Parkinson's Disease and Movement Disorder Society, which is formed by Dr. Singhal and Dr. Maria Barreto has been running it. We have the support groups for Parkinson's patients all over the India. And we have more than 6 or 7 active support groups all over Bombay. And I think the reach of this society has been all throughout the India, even in the eastern corridor of India, like Manipur, Arunachal Pradesh, they have been able to, Nagaland, they have been able to reach. We are now planning to start it in Jammu and Kashmir as well. And there are many states where Parkinson's Disease and Movement Disorder Society is active. Now, what they do is they offer free of charge service to all the patients with Parkinson's disease. You just walk into any of the support groups in India, which is available on the web, where they're located closer to your house, and you can get an access to variety of physiotherapy, dance therapy, music therapy, art therapy, cognition therapy, and a little bit knowledge about your condition as well as about your treatment. So that is one big advantage of Parkinson's Disease and Movement Disorder Society that I see. Coming back to the question that was asked to me about the treatment of Parkinson's disease, early diagnosis, um, the neurologist population in India is very scant. It is not, they are mainly concentrated in the tier 3 cities. Now we are seeing a little bit of a migration to the rural areas. So I still feel that the patients who are staying in the remote places of India do not have an access to the early diagnosis, do not have an access to the management, do not have an access to the treatment. And this is when I went to Gangtok, which is again in the eastern corridor. There is no neurologist in that state. So it tells you that there is no access to the modern medicine early diagnosis. Coming to the city-wise early detection, I think it's quite good in most of the cities all over India. If you have a doubt whether this person has a Parkinson's disease, we have an access to the TRODAT scans, DAT scans, which were not possible a few years earlier, but now they are easily available. They are easily available in the centers all across the India, but it's mainly in the tier 3 cities. What about the treatment access? The drugs are cheap, they are not expensive. The standard drug is levodopa. So a lot of patients can afford it and can take it, and it's still a gold standard into the medical treatment of the Parkinson's disease. People are becoming increasingly aware of the surgical treatment, the number of the surgeries, Parkinson's disease surgeries that people are undergoing have increased, and Paresh will agree with me that a lot of outer states, the smaller cities, tier 2 cities, have also started offering the deep brain stimulation surgery to the patients. The newer drugs may take a little while to come, but with now the DCGI opening up, I think we are getting the newer drugs much earlier than what we used to get them. All the latest medications are increasingly getting available in Indian market. We are also not paying attention to the non-motor symptoms of the Parkinson's disease. We talk about tremors, we talk about falls, we talk about gait, but one must realize that the patients with Parkinson's also have non-motor symptoms. They have constipation, they lose a sense of smell, they talk in their sleep, they have fatigue, they have pain, unexplained pain. They are more prone to developing backaches, knee pains because of the asymmetry of the gait. They have sleep disturbances. And all these non-motor symptoms are the ones which are causing more burden to the caregivers as well as to the patients um, in the Parkinson. I think now we are learning to manage them also in a better way. Now we are paying more attention to the gut because of the absorption of the drug is to the gut, it has to reach the brain. So we are looking at what the gut is doing in Parkinson's disease. How can we modify the gut bacteria to improve the Parkinson's disease? So a lot of research is going towards all these modalities in addition to surgery. So hopefully we should have some kind of a prevention, some kind of a disease modifying treatment in the future. So I think it's a good hope for the people with Parkinson's disease, which is a neurodegenerative disorder, which has no cure as of now.
Fingers crossed, ma'am. And we are also looking for some good treatment options available that is there to not just to when it comes to patient comes to doctors, but also we want this care to reach across the masses, even to the remotest area of our country. Like you mentioned in Gangtok, there is no neurologist. Even if there's some symptoms, where will the patient go for the diagnosis? And I think that's what we look for, the hopefulness that it reaches to the masses. Moving with my next question to Dr. Paresh. So we were talking about the accessibility and how we can build an ecosystem where the disease get diagnosis as early as possible. So when we talk about this, how can access to advanced therapies like DBS we discussed earlier be expanded beyond metro cities to reach a larger patient population?
Okay, so if we have to talk specifically only on the surgical part, I would say that just now I see a limitation in the way this could be. As Charu mentioned, already a large number of tier 2 cities have started performing it. That is because there has been an increased amount of well-trained movement disorder specialists, and all these movement disorder specialists feel the need to be a part of a deep brain stimulation surgery program. Having seen the deep brain stimulation surgery for last several years, almost 30 plus, and having been a part of every innovation or any new advances, I personally still feel that this is something which is not everybody's cup of tea. It is not required for us to have it available at every center. It's not reached the level, to give you a parallel, a level of smoothness, effectiveness, and ease of performance like a CABG, coronary angio bypass, or a knee replacement. So 40 years back, we know the CABG was performed only in select centers, and it has expanded. The reason for this are twofold. CABG or a knee replacement is a skill of surgeon's hand. So if a surgeon is skilled, he doesn't need anything more. Deep brain stimulation surgery is the beginning of a journey, a long journey for the patient and for the caregiving team. Again, Charu would witness this and say that because Parkinson's disease is a progressive disease, after doing deep brain stimulation surgery, actually the journey of the patient starts. So there are two different components of deep brain stimulation surgery. One is execution of the surgery, and second is aftercare and continuous care. Now, we all know that unless we have a tremendous level of case load, the experience buildup is hardly any. So there are centers which are trying to do this surgery and they perform 2 or 3 surgeries in a year. It is never going to be effective for them to take this stimulation. But yes, if we have to make it more effective, more structured training, and second part, sorry, I didn't mention the second part. So one is this journey and continued care. And second, it's a highly technologically challenging program. So even if we have to take it MRI-based asleep DBS, it requires intraoperative imaging, and the top or the most experienced functional neurosurgeons quote that journey of doing deep brain stimulation by just MRI targeting should be undertaken by an experienced DBS surgeon, not by the beginner. So you must have been able to travel across all terrain before you embark upon going for a blinded surgery. So I would suggest that the expansion of the therapy has to be done in a calculated, controlled manner, wherein we have adequate amount of expertise, equipment, support, and volume of caseload. If you do not have the volume of caseload, it is never going to be as successful or as productive, because this is not some simple surgery. So sorry, I should be talking of expanding, but I have my limitation. I have no hesitation of expanding. When we started deep brain stimulation surgery in 1998, we were 2 centers, and it took 10 years, and this is Professor 𝗕𝗲𝗺𝗶 has showed this data in his one of the presentations, and that it took 10 years to build up to 20 centers, and now we have almost 40 or 45 centers around the country. But if you take the high volume centers, there are only 8 or 10.
Thank you so much, sir, for sharing that actual facts and figures and how things are expanding, or they are still stuck, and what how it affects out there for the patients and for the treatment.
We have to be careful, basically, yeah.
So, with this, now I would like to ask my question to Dr. Tarun. So, when we talk about the treatment options that are available to the remotest of area, what scalable models can we integrate to rehabilitate into mainstream Parkinson's care across hospitals and community settings?
Yeah, thank you for asking that. It's a very important question. Again, coming back to like patients who are in tier 3 cities and beyond, like they said, it's very difficult to get a specialist neurologist to who actually can diagnose. So, it becomes imperatively more important for us to have some kind of, hub and spoke model where you can actually initially, have a diagnosis done. And then, when you say hub and spoke, so spokes can be your local NGOs, I would suggest, because, every city, every village will have some kind of NGO. Let it be some other NGO. It may not be a healthcare NGO, but they can definitely dedicate one part of their, even I would not hesitate having a center in any of the temples. Like we have in Gurudwaras, we have a lot of rehab centers, physiotherapy centers in Gurudwaras. And same way, they also have, a medical person sitting there. So, so you should actually be dedicating part of it, which can work as a spoke. And then, from the main center, you can actually, relay what is required for these patients. And there are already a lot of NGOs, like the Indian Head Injury Foundation, another like Parkinson Society, like the PDMS Society, which are already working with NIMHANS and AIMS, having those interlocked, kind of I would say, synchronized way of working, where they're actually doing a lot of studies and actually helping the poor people. And the same way, I think, also it's, I think, our responsibility who are working in corporate hospitals to, kind of dedicate part of their, if not within their duty hours, but, of course, after their duty hours, they should be dedicating part of a few hours actually, listening to these patients. And, these are all patients who can be, like I said in my previous discussion, they can be dealt remotely. So, it's just about, creating that link which is self-sustainable. So you should have something which is also sustainable, right? You cannot have you can just open like those, I don't know, it's not right at this platform, like the mohalla clinics that we had. But then many of them were actually, not really working to that extent they should be. I would not say completely, but many of the clinics were actually kind of redundant, and, there were nobody sitting there actually to help people. So we should have something which is also self-sustainable. So, I think we can do lot many things with the present government. There are a lot of schemes. It's a Bharat kind of a scheme and other schemes where we should pitch in as a group, we can definitely put on to them, like we can table them what is our scope, where what all fits according to the given budget, and I think it can really work.
Thank you so much, sir, for highlighting that how we can make it work. And like you said, the mohalla clinics which were there, and I think the regulation, the motive, the sense of how it should work, those things were is there, which is missing to make it actually work. Because there comes the role of policymakers and the regulators to
Absolutely.
open, yes, to open all such kind of facilities which can actually help on ground for the patients and the families. Uh,
Absolutely.
com- Coming to my next question, Dr. Manreet. Ma'am, since we're talking about that how community settings or can be made to make these rehabilitation system available for the Parkinson care, if we have to talk about that, what policy or ecosystem level intervention are needed to make the support better for patients and the caregiver in the long term? If you could help us understand and understand
Right.
this.
So India's long-term challenge is not about the more number of services that we require. It is more so the structurally fragmented system that we have, the care system that we have. In fact, from policy perspective or from government perspective, we need to have more government-supported respite care facilities, which can be short-term, long-term, both of them. Right now, care is all about family-oriented. So it should be more towards, in the longer run, it should be more from the state's perspective also. That state should also be equally responsive to the care of such neurodegenerative diseases, which you know that they're not going to get better, or the neurodegenerative conditions. So care support in India, as I mentioned, is anyways fragmented. We need to definitely work on that. And also, it is mandatory that our carers are also trained in a much better way. According to the conditions, the carers should be given training. And regular training needs to be given. This can be from government perspective also, even from the private institutions that we have. In fact, in India, what I've seen is once you do nursing, or though there are some programs which nurses have to attend every now and then, but from GDA's perspective in Parkinson's, mostly because it's only an assisted daily care that they require a person for. So these people are not well trained to take care of such kind of conditions. One is empathy is lacking. Secondly, they have no idea about the whole condition. So I feel that in between, there should be brushing up sessions for them as well. Or maybe when a carer or a caregiver reaches an elder's place, that particular family or that particular doctor should take the lead and at least inform the carer about the whole condition and how it is to be meant, how it is to be held, etc., so that the whole caregiving perspective has more routine to it and it is taken care in a better fashion. So the ecosystem redesigning has to be definitely integrated. It has to be an integrated approach, more towards health, social, and technology oriented. And government, I'm sure, is taking steps towards it, and there are a lot of improvements which are happening. But from long-term care perspective, yes, we need to work a lot of policy changes need to happen. And caregiving today is only out of pocket from the family's perspective. It is only out of pocket expenditure. Once you are out of the hospital, no insurance looks after the kind of requirements that have to be met at home. And as Dr. Tarun mentioned earlier, that now it is going to be more of out of hospital care rather than in hospital care. So accordingly, I'm sure the government will make changes to its policies and go ahead with the insurance, etc.
Definitely, ma'am. I think the ecosystem should change according to the time and the need, or the how the things are evolving. Like you said, the insurance and the policymakers should also brush up their knowledge and what needs to be there to take care of the caregivers and to the family or to the patient, and many things which is associated to this. I think this needs a deep level of research, understanding, and the team of how this disease or ecosystem needs to be built for the future, where we can diagnose and prevent the Parkinson's disease in the coming times. With this, we'll be moving ahead to our next segment, which is the rapid fire round. So I'll be asking two questions to each speakers regarding the Parkinson disease and almost of the similar kind of discussion which we had. But I would request some fiery and rapid responses. So starting with Dr. Charulata. Ma'am, how significant is the psychological burden in Parkinson's patient and why is this often under-recognized? I think ma'am is not on screen. Ma'am, can you hear us?
Yeah, I can hear you now. Yes.
Shall I repeat my question?
Yes, yes.
So this is regarding that how significant is the psychological burden in Parkinson's patient and why is it often under-recognized?
So that's a good question, actually. The Parkinson's patient, even before they develop the disease, as I was talking about non-motor symptoms, they have severe anxiety, they have depression, and some of them develop apathy. Apathy is disinterest in the surrounding. And that is something that they have to deal with all throughout the illness. And then as the disease advances, we start having the problems with the cognition, their ability to take decisions, plan their activities, do multitasking, all that starts getting affected. And then the dementia also sits in, which is Parkinson's disease dementia, which is slightly different from the Alzheimer's dementia. Then they start getting hallucinations, which may be drug induced, which may be the part of their illness itself. So it's a lot of burden to carry. And psychologically, I feel that just giving them the drugs like dopamine and then sending them home away is not a solution. We need to look at and address all these issues that the patient faces. And we need to make the caregivers also aware that the patient does go through this. You know, a lot of my Parkinson's patients' relatives will say that they cry easily, even if the situation is not so depressive or it's not warranting or it's not directly affecting them, but they would cry easily, they would get depressed easily, they would get demotivated easily. Keeping up the motivation in the Parkinson's patient itself is a big task to motivate them to move, motivate them to do the exercises, to seek the support system, take help from the caregivers when it's necessary. Their sleep regulation, their bowel and bladder, urinary complaints, all these things play a very significant role in their day-to-day lives. So it's a really big burden to fight this disease, and you need to make your treating doctor aware that you're going through these symptoms. A lot of Parkinson's patients don't think that this is the part of the Parkinson's disease. They don't mention these symptoms. So I think from the neurophysician's point of view, it is mandatory for us to ask these questions rather than just presume that the patient is going to volunteer and the patient is going to talk about it. We all are in a very busy schedule, tight schedules. We give barely 15 minutes to each patient, 10 to 15 minutes to each patient. So it's very, very difficult to address these issues in a visit in the clinic. So I think a lot of support system like having a Parkinson's nurse or a care or a physiotherapist who understands Parkinson's disease is very essential part of the team. And because our center does the deep brain stimulation surgery, we have been able to form a team which provides a lot of support to the patients. But I think in the smaller centers, this kind of a support is also needed, and the awareness of these symptoms is also very important from the physician's point of view as well as from the patient's point of view. So just writing the prescriptions and writing the antidepressants is not going to take away their symptoms.
Thank you for that response, ma'am. I have another question for you of our rapid fire. That one early symptom of Parkinson that people should never ignore.
Difficulty in walking, difficulty in balancing, they should never ignore. So that will result in a fall, that will result in less ambulation. And that's one symptom they should ignore. I'm not so worried about the tremors, which is what brings them to the doctors. But balance is very important in Parkinson's disease.
I think that is something which people should look first.
Correct, rather than the tremors.
Yeah. Thank you for that, ma'am. My next question is to Dr. Paresh. Sir, the biggest challenge in managing Parkinson's today?
I think the awareness and availability of a structured, organized, comprehensive program. And this is not about the developing countries only. It is a concern about developed nation also, because Parkinson, as Tarush discussed earlier, has got a lot of non-Parkinsonian issues, like all the non-motor symptoms that she mentioned, will require to be addressed adequately at Jaslok Hospital. And that is why I always continue to remain at Jaslok Hospital, was that over 15 years we have developed a multidisciplinary team. And apart from, and I told earlier that it is a journey surgery which starts with surgery. So the patient is going to require your help for next 15 to 20 years. And during this time, you require a urologist, you require pain physician, you require a psychologist, you require a psychiatrist, you require a gastroenterologist. All these people you would require, and unless you have people who have worked along this space, in the same space along with you for a long period, they will be otherwise looking at each of their problem in isolation. So gastroenterologist will say, constipation, you take this pill, or you get endoscopy done from the top, from the bottom, this and that, and all that. So that is what I would say, comprehensive care.
Comprehensive care is one. And if we have one way to integrate mental health support into routine Parkinson care protocol, what would be that, sir?
You would have to explain. I didn't understand. Mental health support?
Yes, ways to integrate mental health support into routine Parkinson care protocol.
It should be starting from the beginning. And as Dr. Manpreet has been talking, we have a very strong leaning towards caregivers. So I would recommend that the mental health support should not be only for the patient, it should be also for the caretaker. And it should be coming from all aspects, depending on which patient requires what. Because today Parkinson is a manageable disease. Someone should not be leaving his job or leaving his hobby or losing his profession just because he got Parkinson disease. Definitely not. So for them to understand this and to take them through the journey, a good mental health care program would be essential.
Very rightly pointed out, sir. Thank you so much for addressing that. My next question is to Dr. Tarun. Sir, one innovation that will transform Parkinson's care.
I think, like I said, innovation in terms of app-based therapies is very important. That is something which is accessible. I would say mobile is something which is a boon to the society. A smartphone, using a smartphone has changed the way you're looking at healthcare, starting from booking a consult to actually doing a consult with the doctor, with your physical therapist, with your occupational therapist, and how you can reach out to a multidisciplinary team through your smartphone. I think that is something which has changed the scenario, and I think there's a long way to go towards it.
And next is one myth about Parkinson's that must be broken today.
Yeah, so the myth is, patients come to me, they said, we've been told that, at the end of few months or few years, you'll be landing up on in a bed. So that is something that is one of the myths. So that is why we say, early diagnosis, early rehabilitation is very important. Like my other colleague said, now, patients are being referred by them to your nearby physical therapist or to your occupational therapist, and of course, to your speech therapist. I didn't mention that earlier. Role of speech and dysphagia therapist is very critical in terms of, when you talk about Parkinson's rehab, because many times we look at the motor aspects, but sometimes, like talking about the mental aspects and the following aspects, we think that is just part of the disease and we tend to ignore it. But, that can lead to a high level of aspirations, and it can be really dangerous for the patients. I think that is important for us to work as a multidisciplinary team.
Thank you, sir. Thank you so much for addressing those points. My next two rapid fire question is to Dr. Manreet. Ma'am, one advice for caregivers you would like to give?
So caregivers, I would like to advise that caregivers have to be a little more patient, more empathetic and more patient towards the elder who's got this condition. Because as we know, it is not going to improve. It will deteriorate over a period of time, but if taken care well with all the aspects that my colleagues have mentioned, Dr. Tarun, Dr. Desai and Dr. Charulata, I'm sure with such kind of advancements coming in controlling the condition, I'm sure it can at least become better or at least manageable if they are more patient and more empathetic towards the elder who is suffering from Parkinson's.
Thank you for that advice, ma'am. And the last question is, what gives you the hope in Parkinson's research or about the future, I would have to ask?
Since AI is coming in a big way, Dr. Tarun has been talking about that there are so many sensors which are helping him assess the gait, assess the other requirements that he needs to know about the patient. With such kind of AI innovations, I'm sure the treatments are going to improve and going to become much, much better. For all you know, maybe in a couple of years, we are able to treat it as well.
Thank you so much, ma'am, for giving that advice and that research. You're hopeful for the Parkinson's care in the coming future. And with this, I would like to thank all the speakers, Dr. Charulata, Dr. Paresh, Dr. Tarun, and Dr. Manreet for being with us and creating this awareness on World Parkinson's Day for the families and for the caregivers, most importantly. It means a lot for us as we work for this cause where we can prevent the the Parkinson's disease there. Thank you so much, and thank you so much for sharing your insights and expertise with us.
Thank you.
Thank you.
Thank you, sir. Thank you.